Excellent. Good evening, everybody. I'd like to thank you for all joining us for our fourth session in our ANZ Virtual Venous Forum. Today we have a very esteemed panel. You'll notice some of the faces from locally, and of course we have Dr. Rick De Graaf back with us, and also Dr. Tjun Tang from Singapore joining us this afternoon. I hope that the daylight saving hasn't thrown a spanner in anyone's work too much. Now, just before we start, there are a few things with this Zoom forum that we would like to pick out. At the bottom of your screen, you should see a share icon, or not a share icon, a chat box, or where you can actually send questions, a Q&A box. Please feel free through the session to send your questions, and we'll attempt to answer them either live online or type your answers in so that you can get them straight away and have your pressing questions answered. Now, where'd that go? Here we are. I've got too many things open. Of course, we'd like to thank both BD Bard and Philips for sponsoring these sessions for us. Without them, we would not be able to put this special session on for us. And tonight we have our 4 talks. First of all, Professor Ramesh Tripathi will be talking about endophlebectomy and its current role in the treatment of venous disease. We will then go on and have Dr. Phil Puckridge speaking about something very novel, about atherectomy in veins. Then we'll move on to Dr. Tang from Singapore, who will be discussing his results of an Asian cohort for his post-thrombotic and non-thrombotic iliac vein stenting. And then we have our prestigious Rick De Graaf, who is going to be discussing about ancillary endovascular techniques to support iliofemoral stenting. This is our panel. Our first speaker is a vascular surgeon from Queensland who has made it back from operating all day, and he's going to talk to us about his experience with endophlebectomy and its current role in the treatment of venous disease. So I'm going to hand over to Ramesh.
Hi, Steve and Rick and Phil. Good to see you guys. And let me see if my presentation is opening. For some reason, it refuses to open. Just give me a second.
It's always the way, isn't it? You have it up. We had this up exactly 3 minutes ago. Not an issue. I don't know, Ramesh, while you're doing that, are you able to answer just briefly? I mean, how many times would you need to do endophlebectomy when you're treating your vein patients?
Not very often. I think it's only an extensive disease where the disease is extending into the profunda, or if there's a need for doing something more in case there is a non-healing ulceration, and there has been a failure of stents which have been put across the inguinal ligament, and still there is some kind of obstruction or a restenosis. In those cases, endovenectomy can work really well. My presentation is ready, so I'll go to that.
Fantastic.
Are you able to see my screen?
Not yet, not yet.
Okay. Let me see, share screen. Share.
How's it going?
Okie dokie. Looks good to me.
We can't see it. Ramesh, have you got a dual monitor there, or are you using a single one?
Single monitor.
Yeah.
Yeah, I've got it now. Let's share this. Are you able to see it now?
Got it.
Okay,
Fantastic. You might want to go to the, yeah, perfect.
So what are the indications for doing endovenectomy in patients who have had iliac vein stent placement and how I do it? I have no disclosures. If you look at the failure modes of iliac vein stents, the most common form of failure mode is due to poor inflow. And in my practice, I've seen up to 51% of the failures are due to common femoral vein disease. About 26% patients would have neointimal hyperplasia, 11% due to poor outflow, where the stent has kinked or there has been a slippage of the stent where a obstruction at the outflow area has been missed. And in 9% cases, it's often poor stent choice or overlap or misalignment of stents causing some form of narrowing. And then there is the prothrombotic states. We do not exclude patients with prothrombotic states to do iliac vein stents, and sometimes they do have recurrence of thrombosis. So good inflow is the key. If you look at the treatment options when patients have got femoral artery disease, you can either proceed to endovascular stenting of the common femoral, the femoral vein, as well as the profunda. And I have often seen in my practice that when you do the stenting of the profunda vein, it often comes back with a restenosis or occlusion. So I generally do not do any stenting of the profunda vein. I limit my stenting to the common femoral vein, and I don't even go across into the femoral vein. The other option could be endovenectomy, whereby you could do a hybrid procedure where you could open the common femoral vein, clear up all the synechiae and trabeculae right up to the end of the femoral head, under the inguinal ligament, and then introduce a sheath and go antegrade and stent the iliac vein. Just an illustration of a case which I did. We did a iliac vein stenting, and this patient's ulcer was not healing. So we went back again to look as to what's happening. And as you can see, there is a lot of residual thrombus. This is a post-thrombotic syndrome patient. And so there's a lot of residual thrombus, and it's a lot of stenosis of the common femoral vein. And there is residual thrombus extending right into the profunda vein. And in this technique, we go through the great saphenous vein and loop into the profunda vein from the great saphenous vein side, and you could do very good venograms and show the pathology there. So this patient, I think the order is different. Yeah. So in this patient, we went from the opposite side through the stent, and then we extended the stent into the common femoral vein, as you can see below the inguinal ligament. And now we had a free-flowing stent with no obstruction. And then on the right-hand side is the final picture where there is an unimpeded flow into the IVC from both sides. So I think that stenting can work below the inguinal ligament as long as it is limited to the common femoral vein. And this is the premise on which this stenting is limited, because if you look at figure C, when a stent is extended beyond the profunda vein, then often it can cause pseudointima in the stent and block the profunda vein if it is a closed cell stent. And also it can reduce the flow from the profunda vein. And also if there is profunda disease, then that disease is not addressed. And so you are relying mainly on the inflow from the femoral vein, which is mostly occluded in DVT. So also the other problem is that there are multiple channels in that area if there is heavy disease, and therefore you could only go through one of the channels, and when you do a stent like that, you can push some of the trabeculae in front of the ostium of the profunda, so as to speak, and cause obstruction. So always a good rule, as I've shown in figure D, to do a generous endovenectomy of the profunda and the common femoral vein, and then put a stent on top of that in the common femoral vein. This is a video that shows exposure of the common femoral vein, and this is dissecting out the trabeculae. And these trabeculae are not like doing an endarterectomy, because they are stuck to the wall and they have multiple, feet, so as to speak, stuck to the wall, and therefore a combination of blunt and sharp dissection is needed. Especially around the orifices, it's important to make sure that you don't cut around the orifice and create a hole there. The other issue is right across the profunda origin, you have to take away all the trabeculae. As you can see here, if you had gone through one of the holes in the trabeculae and put in a stent, the rest of it could have formed a curtain in front of the profunda vein. So this is step-by-step removal until you find a glistening intima or whatever is left of it in the femoral vein, and you extend it right up. And once you have cleared this, and you can see this comes out like a rubbery hard mass, and then you look at any extensions inside the profunda vein. You open the profunda vein and make sure that there is a good backflow coming from the profunda vein, and any fibrotic material across the profunda vein orifice, which can potentially become obstructive, is all excised piecemeal by piecemeal. Once this is done, then a sheath is put into the common femoral vein going towards the iliac vein, as you can see here. The sheath is placed, the rest of the tissue is excised, and obviously, as you can make out, there's a lot of tissue going up into the iliac vein as well. And if the vein is generous size after the endovenectomy, you can close it primarily, as I'm doing here, and then you can release the clamps to allow profunda flow coming in. And then you can do an angiogram, a venogram, and then wherever the narrowings are, you can stent the vein and get a good result. So even after the stent placement, this is after a balloon angioplasty, and this is after stenting. And this is the closed vein at the end of the procedure. So if you look at endovenectomy results in our limited experience, iliac vein stenting across the inguinal ligament, we have done 33 cases, and we've only done 9 cases of iliac vein stenting with endovenectomy. The numbers are small, so I wouldn't be too serious about the p-values, but if you look at the general trend of primary patency, secondary patency, and freedom from ulceration, there's certainly a distinct difference between the endovenectomy group and the iliac vein stent group. This is in the background of the fact that iliac vein stenting with endovenectomy is required in a far less number of patients than you would do a iliac vein stenting across the inguinal ligament. So in terms of, ulcer healing, the results of endovenectomy are pretty satisfactory. So the key technical steps of endovenectomy involves clearing of profunda inflow, as well as the common femoral vein outflow at inguinal ligament, stenting distal to the common femoral vein clearance point, avoiding wound complications by VAC therapy, because these patients have to be anticoagulated and they can develop wound hematomas, etc. So I generally don't I just close the femoral sheath and put a VAC for a few days, and then you can close the wounds later on. Because there's also, because of the limb swelling, there's a lot of lymphatic ooze in the wound as the lymphatics are being decompressed. And I anticoagulate these patients for 3 months. Thank you for your attention. Steve, you there?
I'm here. I'm back now. That was an excellent presentation, Ramesh.
Thank you.
I got you specifically to talk about that because I think out of anyone in Australia and New Zealand, you've probably got the most experience with endophlebectomy around in this side of the planet anyway. But can you just explain something for me? When you were talking about your decompression at the end of the procedure, you said that you leave the wounds open with a vac on it. Did I get that right?
That's correct. Because in our initial experience a few years ago, we were having wound complications like about 40% patients, especially when you fully anticoagulate the patients. And also the lymphatics that were being decompressed, you had a large amount of output, from the wound. And we relooked at what was happening, because when the lymphoseromas and hematomas develop, then we had to open the wound to drain them anyway. So we stopped doing that. We just closed the femoral sheath and then put vac dressings, and we found that the complication rates came down drastically. So I think this is a good way of doing things, because it's only temporary. The patient is in the hospital. You can mobilize the patient with the vac dressing. And, in the initial phase, when you're mobilizing the patients, the lymphatic output is quite significant. I have patients who have had almost like 700 mils of lymphatics come out over a period of 48 hours. So that's very impressive.
Oh, definitely with swollen legs. The endophlebectomy, it just seems that we're slightly headed away from it because we've got stenting and we can stent into the profunda and the femoral vein itself. Rick, what do you think about that? Should we be stenting or still doing endophlebectomy? I know you can't do it, but
I think nobody knows the real answer, because the numbers are small, and we need to get various people, and Rick might be able to tell us more about it. We need to have enough number of patients and look at their outcomes, short term, mid-term, and long term of doing profunda stenting. Because of the results that I have achieved in my patients, I tend to go with endovenectomy. If something extends beyond the profunda origin and across the profunda origin, and on MR or CT venograms, you can sometimes see, and also duplex scanning, you can correlate that there is heavy disease. and the lumen has significantly narrowed. So in those patients, I think I have no hesitation in going towards endovenectomy. But if, there's a patient, these patients can be very obese and they can be large, and they can really be bad surgical candidates sometimes. And in those situations, I think it's reasonable to go for a stent first and see how things happen. But nobody really knows. The jury is still out, and we need some more solid studies to be able to conclude that stenting into the profunda is a good thing. It has not been such a good thing in our experience in the past.
Yeah. What's your comments on that, Rick?
Yes, I've got a couple of discussion points at the end of my presentation. And if you would allow me, I would rather discuss that at the end of the session, because I think that fits well there, because we can really get some insights and outsides of that procedure.
Absolutely, we'll do that for sure. Just for the attendees, don't forget there is a Q&A section at the bottom of the screen that you can actually type in questions, so please feel free to do so. Well, look, we'll move on to Dr. Phil Puckridge's presentation. Now, Phil, as you know, is based in South Australia, Flinders Hospital, and I've asked Phil to talk about his experience on atherectomy in veins. There's not a lot out there on it, and Phil has done it a few times, and I think he should, I've asked him to share his experience with us. So I'm going to hand over to Phil.
Thank you very much, Steve. Thank you for having me back to talk again, and I hope that everybody who's joining us tonight will actually benefit from this discussion. I am going to try to share my screen, and can you see my presentation? You're muted, Steve,
yes,
so I better check.
Yes, you can.
Just
Excellent. Put it in presentation mode.
Excellent. Is it in presentation mode?
No, it's the normal mode.
Done, because it looks like it's in presentation. Your screen sharing, stop sharing. Let's go to that slideshow, resume slideshow. Are you seeing it now? No.
Not yet.
This is disappointing.
Sorry. Are you on a Mac or Windows?
I'm on a dual screen, which is a technical problem.
Yeah.
And I will try to fix my problem. Let's screen share.
I know exactly what you mean. It's
how's that? Can you see that?
That's perfect.
Okay, I may just not be looking at you because I'm looking at my other screen for the Zoom pictures. And I apologize for technical difficulties.
Anyway.
All right, so atherectomy in veins. Well, it's an interesting concept because it's not really designed for it. What do we know about restenosis after venous stenting? Well, we have various reported incidents of restenosis. The best is probably suggesting that we may need to re-intervene in about 13% of limbs, and Raju's group published that data 10 years ago, that they re-intervened in about 13%. And the causes of this this re-intervention are either due to new lesions, which are untreated or at the edge of the treated segments, or due to in-stent restenosis. And it may be that we do get an intimal hyperplasia as a response to the presence of the stent, but this is not well researched. And once again, it's been thought to be put into 3 different components just by the way treatment response has occurred. And you can consider that there are soft restenoses, which are treatable with angioplasty. And it's been proposed that this is actually layered thrombus. It's still fibrous tissue, it's still organized potentially, we think, but it will squeeze out of the way with angioplasty. And then there's this more hard fibrous material, which when you angioplasty, it deforms the stent, but the in-stent restenosis doesn't actually change. Or you might have fibrous external compression on a stent causing what appears to be in-stent restenosis. And if that's a wall stent, which we don't have really in Australia, you might be able to hyperdilate it and get some benefit, but generally speaking, it's a problem. So I wanted to share experience of one of my patients who has had previously IVC stent reconstruction for chronic occlusion after DVT, then came to see me secondarily. This original treatment failed for multiple issues. He's left with a chronic occluded system, and symptomatically he was wearing a grade 4 stocking at nighttime to control his symptoms and prevent edema. And through all this, he was trying to work as a personal trainer. We did retreat him. We were able to actually successfully open things up, and we re-stented everything. But he had a significant problem of external compression at the iliac bifurcation. Sorry. The iliac vein confluence, get my words right, we're in the veins, not arteries, Phil. And we had to have a solution to that. And in his case, that was a surgical solution with a interpositional PTFE graft. But that graft itself was non-compliant, of course, and would collapse when he wasn't using his legs and had to be stent reinforced. So this all gave him a improvement, much better, but he's had recurrent issues, and he's got recurrent issues with hard fibrosis, filling the stented iliacs, which are actually now 2 layers of stents, and also flow layering, creating tissue growth in the central aspect of the confluence of the iliac stents. Now, we've re-angioplasty this multiple times with minimal benefit, but temporary improvement of symptoms. And so I was left trying to decide what to do. And our colleagues in Sydney, Dr. Robertson, in conjunction with Shannon and Ramon and Steve Black, published last year a case report where they performed atherectomy of a limited section of a left external iliac vein restenosis, found material in there which was similar to neointimal hyperplasia when they removed it with the Hawk-1 atherectomy device. The Hawk-1 atherectomy device is this one. It's a directional atherectomy device. It's important to understand it cuts on one side. What drives the ability to push this cutter against the wall is the jog, or the angle in the actual catheter before the cutter opens when you activate the device. And that, I hope you can see my mouse moving, but that is the angle of the jog, and this then has a double angle to open and cut. The issue with that is I'd point out that it's designed for arteries up to 7 mils. So when we start to get in a bigger system, that jog doesn't push off and actually engage as effectively. Therefore, you might cut, but you might not cut much. And I've got a long-standing experience with directional atherectomy, first doing my first case in 2007. This was with in-stent restenosis within arterial disease, and my experience was that we get less embolization when we're in fibrous material than calcified plaque. When we're doing what I'm talking about, we are definitely outside the IFU, and the largest device is designed for this up to 7 mil vessel, and to create a good lumen for a 7 mil vessel. For hard fibrous tissue, though, what options do we have? And so in discussion with him over a long period of time, and we've decided to attempt atherectomy to clear some of his problems. And these are some of the pictures from that. This is his left iliac system. Now, that doesn't look too unreasonable, but it is much worse on intravascular ultrasound. And here is the jog of the atherectomy catheter. In this attempt, we're coming from the femoral vein up into common femoral vein and stent to common femoral vein. The stenosis here, he has one down here, but he has higher up stenoses as well. And you can see the jog's not only just touching, it's not really pushing out the actual atherectomy device. There was some improvement. Other pictures on this second attempt to treat him with atherectomy show us in trying to improve the diameter at the confluence of the iliac veins within this stented segment, and it struggles to touch the walls there, and even further down the iliac vein, I was able to get it out to tissue and cut, and after multiple passes, significant volume of materials was removed. But realistically, when you're looking at that with intravascular ultrasound, it's less than what you really think. And for example, on the top right-hand side, this is the left proximal common iliac vein post-directional atherectomy. You can actually see that there are a couple little divots cut out of the area. Your ability to control where that will be is quite difficult. And we've increased from when we did the atherectomy to angioplasty afterwards, an additional 12 millimeters mercury, 12 millimeters squared. But, you know, we're not getting big diameters. We are achieving reasonable up to 10 mil diameter right at this point. In the IVC, there was some improvement, but minimal change. And on the right-hand side here, the interesting thing with this picture on the right side of my screen, labeled right common iliac vein, is the irregularity of the lumen, fibrous lumen within the stented section. And this is due, I unfortunately don't have the pre-picture to show you, but this is due to the atherectomy. It was a concentric ring. We've done atherectomy through that. We've been able to choose some material out, but we still have significant material seen on IVUS outside the green line within the stented segment. So we never really got out to a situation where we could clear this tissue from within that second layer of stent and provide him with good luminal gain. From our histopathology, slightly different to Dr. Robertson's paper, the first time we submitted them to our pathologist, they said, look, this is just organized thrombus. And when they looked at them on the second lot of specimens, they said, look, there's blood, it's blood vessel wall with fibrinoid degeneration, myxoid change and fibrosis, but very much bland sort of material, very difficult to indicate what is happening there and whether it's truly like a neointimal hyperplastic response like you have in arteries. I don't think on histopathology you'd be able to tell. So is there any benefit from doing directional atherectomy in veins? I think the benefit, honestly, is minimal. This is incredibly time consuming. We did see on intravascular ultrasound evidence that we had cut the tissue, we had debulked slightly, but when it really translated to had he gained much benefit, it hasn't really made a big difference for him personally. You at the time are running a potential embolization risk. There's no filter available to sit in the IVC of appropriate size. Are there other options? Well, certainly there's publication of case reports using Rotarex to help situation of recanalization. Pantheris may be useful with the IVUS component to it or the OCT component to it. You know, these are not designed for these big systems when you're trying to actually deal with this in this way. The benefit we've seen with this really has been relatively minimal, but the tissue collection has been interesting. Thank you very much. I'll stop sharing.
That was really interesting, Phil. Really, really interesting. You can see in relation to your stents, atherectomy that we have at the moment really doesn't touch the size. It has no impact. Even when you were seeing on just the 2D imaging with the X-ray, It looked tiny compared to the stents that we put in the venous system.
Look, exactly, and the issue that we had is we spent easily 3 hours doing atherectomy, and removed what looked like a significant, compared to what you take out with atherectomy and artery, is like, wow, we got so much. And then you go back and IVUS and go, it's really hard to see it's that much different. He woke up somewhat short of breath after the procedure. He wouldn't allow me to do a CTPA, which is frustrating. He's fine now. He's back to working. But you're left going, I'm not sure risk benefit is really here. If the effort involved really translates out. And certainly in that case, it didn't. In the case that they published out of Prince of Wales, however, the patient did very, very well. And, I think that's in some ways similar to the whole atherectomy story. My first patient in 2007 never needed reintervention again, ever, for their stent after I treated it with atherectomy. But N equals 1. And a lot of patients since then I've treated have had a lot of restenosis after atherectomy, even for in-stent restenosis with arterial disease. So, whether it's a real benefit to the patient, I doubt at this stage. It's not the answer. Have you frozen, Steve? Because you look very frozen.
Phil, is there a danger that the atherectomy device can get caught in the stent?
Well, yes, there is. Jen, and
Question. I missed what Phil said, so I apologize if I'm going over, but just we've got the panel here before Phil comes back. Has anyone else had any experience with the atherectomy devices?
I'm back. Sorry, I dropped out there for a moment. Sorry about that.
Don't worry, I did too. So apologize. That's okay. Has anyone else had any experience with the atherectomy devices?
Yes, I have, Steve. Hi. I mentioned this morning. I've used, yes, it doesn't work. It's not big enough. There's no big enough atherectomy device that will deal with anything inside the stent. I've done it for ISR. I used the Rotarex because I'm quite used to using the Rotarex in ISR within the arteries. And I used their 8 French one. It doesn't touch. I did for a restenosis and a reocclusion. It really doesn't do the job. Yes, you can get a core, but they restenose very quickly after that. And it doesn't last very long. And you do core a channel, but it's not satisfactory. And you put the IVUS back up, it's not satisfactory at all. So I think you're dealing with a different type of beast. I don't think we've got a handle of that, of the tissue that's involved using it. So I don't think it works at all.
It seems also that we have another problem, which there was a question from Steve Merrilees, which I'm going to get us all to comment on. But before that, it's an interesting question where we've got near-intimal hyperplasia in arteries. Is it the same beast that we're dealing with that is causing the narrowing in the veins? What do we think?
I don't think so. If I can take that question, I don't think so, because I agree with Phil that some of the endovenectomy specimens that have been sent, the trabeculae have been sent to histopathology, they don't show neointimal hyperplasia. And also, if you put a stent and in response to the stent, if there's a regrowth, it's most likely to be because of rethrombosis around and inside the stent, rather than neointimal hyperplasia. I know there's a case report which was published saying that it's the same thing and has got characteristics of neointimal hyperplasia, but I have serious doubts. And I think more studies need to be done, including genetic, evaluations of the specimens, and also characterization of the cells in there as well to actually determine what's really causing it.
Yeah, I think Phil's study shows that it's mostly extracellular matrix and rather than the neointimal hyperplasia. But is that right, Phil?
I agree with Ramesh. I don't think it's a true neointimal hyperplasia. I think, in fact, I probably should qualify that to say, look, more work needs to be done. However, there's lots of reasons for this to occur, and when we stent a vein, we change things differently to when we stent an artery. When we stent an artery, we create a irritation, and there's a neointimal pipe response. But when we stent a vein, one of the other things that we change is we change the fact that it's no longer a compliant vessel, and it can't change diameter in response to need. And that's what veins do. So you will have situations when flow will be slow and flow will be fast, and you will get microscopic adhesion of thrombus to the wall of the vessel, and then you'll layer it, and then you'll fibrose it because thrombus organizes. So I think we do end up with a bland material which looks similar to neointimal hyperplasia under a microscope, but I'm not sure that we can say the pathological mechanism to get there is the same. Therefore, the ways of treating it may not be the same. And until we know more, we're just, it's supposition.
Yeah, that leads on to 2 points. The first point was the question that Steve raised, and that was, what do we think about the role of DCB in treating these types of recurrent luminal narrowing that we're seeing in stented veins?
Yeah, we'll answer that.
Go ahead, Rick.
That there's no need for that because simply we don't have any proof that it's neointimal hyperplasia. In fact, the contrary. There's, I totally agree with the former speakers that neointimal hyperplasia is not definitely not instant. Stenosis is based upon that, and it also makes sense because we know that post-thrombotic tissue doesn't have any smooth muscle cells inside. So how do you get to that to neointimal hyperplasia and smooth muscle proliferation if you do not have any smooth muscle cells in those specimens? That actually was Necklin that also proved that in the endophlebiectomy specimen there were no smooth muscle cells. So the only chance that you would have neointimal hyperplasia would be that you would go through primordial cells attaching to the stent, and from there on make that possible. That's highly theoretical and very likely not to be true.
And also people, if you've done stents in the iliac veins where there is a pre-stenotic dilatation, you put in a stent and you follow these patients and they come up with a lining inside the stent after a little while. And it's obvious that the vein has remodeled and stuff is growing from the wall and layering the stent inside. So I think it's more myxomatosis rather than, neointimal hyperplasia.
Sure. Just another thing with the atherectomy, like, do we think atherectomy may have a role, say, in the common femoral vein extending into the profunda, breaking down some of those trabeculae and synechia and creating a bigger luminal channel?
I mean, that's an interesting application, and I think that certainly it can cut tissue. A directional atherectomy can cut tissue. If you are in a environment that you have a small enough vessel, then you might be able to engage that tissue. But it is an interesting concept, but I'm not sure of its practical applicability.
Cool. All right. Sorry, go Rick. Yeah.
No, so I've seen, of course, surgeon, so I don't know what I'm talking about. But I participated in almost all of those anaphylactomies that we did in Maastricht, and I thought it was it's a difficult procedure, and it's very delicate. So it means if you really want to scrape it off the vein wall, and it's very thin, I mean, you can almost look through it. So how would a rather robust system take care of that? You know, to really cut that exactly from the wall. I don't believe that it's technically possible. But of course, then again, I'm not a R&D person, the engineer. They're very smart. So probably maybe they are capable of finding something. But I don't see at least any of the systems that are on the market now. They are absolutely not capable of doing that.
All right. So for veins, we should be leaving atherectomy devices on the shelf. So let's move on to Dr. Tang, Tjun Tang. We've got, he's just joined us from his operating theatre. And he, hello.
Hi, Steve. How are you?
Very well. So good to have you with us.
Thank you very much.
Dr. Tang is going to be talking about his experience with the Venovo venous stent in the treatment of non-thrombotic or post-thrombotic iliac vein lesions and the short-term results from his multi-center Asian cohort studies. So I'm going to hand it over to you, Tjun.
Thanks, Steve. This is very short notice, as you can see. So I've been putting these slides together this morning for you. So just bear with me.
Thank you so much.
If I can find this talk.
Are you able to share your screen or not quite yet?
Hang on, man.
No problem.
Just wait 1 second.
Tjun has graciously stepped in for us at the very last moment, and I appreciate your help. So take all the time you want. In the meantime, oh, there we go. Now, have you got a dual screen as well, or is it there we go. I'll hand it over to you.
Do that, Steve. So thanks very much for asking me to give this talk at short notice, Steve. I've been scrambling for my slides this morning. So
can you stop
basically,
short notice?
So basically, we've got quite a bit of experience using the Venovo stent here in Asia, and I'm happy to share this with you guys. This stent came into Singapore in April 2018. And since then, I think this is one of my go-to stents. I think it's probably one of the best performing stents for what we need at the moment. It's probably the most ideal of the ones that we've tried, and we've tried quite a number of them now. These are my disclosures for this talk. So as an introduction, basically there's two types for chronic iliovenous obstructions. You guys will know, post-thrombotic and non-thrombotic iliac lesions. The majority of lesions that we have in Singapore are the nivels. It's probably a referral pathway issue because our hematologists are not that keen for us to treat iliofemoral DVTs, the acutes, and they still believe very much in using warfarin and NOACs to treat it. So we don't get that too many, and probably the split is about 85% to 15%. So some of these are the types of legs that we get, and actually it's very common, and these are all chronic. And they come to my clinic, and then normally from other hospitals as well, because deep vein stenting in Singapore hasn't really taken on, not only because of cost, but also probably of expertise. And the ones we get are these types, and they present very late. Even our varicose veins patients, they don't tend to present as SEEP2, they tend to present as SEEP4A and even 6. And a lot of the ones that I block for superficial vein venous insufficiency are for SEEP6 disease. So we know that iliac stenting has become the treatment of choice for these chronic lesions. Stents have superior durability than just simple venoplasty, so you should be stenting. Obviously, it's minimally invasive, it's low risk and easy to perform, and it's been shown to be safe in the iliocable veins. And we get a lot of May-Thurner syndrome, actually, and over 50% of our cases have some sort of May-Thurner lesion, but they also get concomitant lesions down the common iliac vein. So when do we intervene? I mean, this is it's quite a nice slide there showing that the level of evidence for treatment post-thrombotic syndrome It's probably the highest, but you've got more to lose ultimately, because the stent actually probably blocks off quicker than you would with a nibble lesion. As I said, we don't tend to get too many PTSs, and if we do, these tend to stay open, but we keep them on longer terms of anticoagulation, and it's one of the issues I will address in this talk. I tend to treat those who are C3 and above, but even at C3, I have to have a very good reason to treat them. And I try to defer that because I only think that in about 50% will get better. So this, we presented this recently at one of the Asian meetings, and we've recently had this published in Phlebology, but we looked at our experience between two centers, one in Taiwan with Jimmy Tan and one with myself. So we put together all of our Venovo stent data, and actually we've got 2-year data recently actually, so which we're going to present very soon. So it's our deep venous stenting, and then we looked at stent patencies and clinical outcome. It's a prospective study. And when you consider with the stents issues, you know, we want something that obviously is longer lasting. And that's why I went for the Venovo, because I think it gives a balance between high radial force and flexibility. The Venovo stent is purpose built for the venous structures we know. It's a triaxial delivery system, and it doesn't move when you deploy it. And it is an open cell as you compare to a closed cell design. And I think it gives you that flexibility, and it gives you the high radial force that you typically need at the iliocaval junction. We know that it's on the delivery system, it's got a fast open wheel and a slow closing wheel. And it typically goes through, I typically push this through a 10 French sheath. And these are the diameters and the stent lengths that there are. So it's actually quite versatile. You can choose. I do everything through a 10 French sheath through a mid-thigh puncture, so I don't need to change up or down, and obviously to accommodate the IVUS. And I do everything with IVUS. I think if you don't use IVUS, I think you're missing a lot, and I think you're doing the patient a disservice. So 2 centers, all of these patients had a preoperative intravascular ultrasound or CT venogram or MR venogram, really to look for extra abdominal masses rather than compression itself. We found in a recent study that we did, we're comparing CTV with IVUS, that we tend to miss a lot of lesions on the CT venogram anyway in over half of the cases. And actually what we did based on IVUS changed what we did. And so I actually offered an IVUS even if I've got a high suspicion of a deep venous problem. We used the Volcano IVUS probe so that it can get out right to the diameter of these large veins. And we had 61 patients with 72 limbs with a median follow-up of 175 days. In fact, we've actually got all of these out to 2 years by the end of this month, with a median age of about 66.5 years. And you can see the split between male and females. And you can see quite a lot of these have advanced stage of disease, and a lot of these had had an ulcer. In terms of demographics, high BMI is expected, and a lot of our population here in Singapore are diabetic, but interestingly, only in this about 1/3 were diabetic in nature. In terms of what we found, I think this is going to highlight what I said earlier. You don't tend to necessarily need to have deep venous reflux to actually find a subsequent obstructive lesion. And only 1/3 of these patients showed a compression on the preoperative CT venogram or MR venogram. As you can see, nearly 40% had CEEP6 disease. And I tend to be much more aggressive with these types of patients because obviously we want to get that ulcer to heal much faster, as we can see from the data, as well as keeping a remission time, longer remission time. In terms of lesion characteristics, as I said, nibbles make up the majority of our lesions, although we do get some PTSs, but some of them can be really tricky because after about 5 to 6 years or 5 to 10 years, they come and it's completely occluded, but they want that opened up, and that can be quite tricky. And I tend to use a CT venogram as my pre-op imaging of choice. So in terms of procedural characteristics, we deployed 73 Venovo stents in these patients. Altogether, we used it in combination. I like this combination with the sinus obliquus stent. I'm not sure whether you have it over in Australia, but I tend to use this for the iliocaval lesions or the May-Thurner lesions, Mean operative time is around 75 minutes, and all patients were pre-dilated. All the lesions were pre-dilated before stenting, and we used a median of 1 stent per limb. As you can see, from the pre-imaging to the post-imaging, we tend to use obviously IVUS pre. We measure everything before, and then we measure everything afterwards. And this is just a very short slide on the oblique stent to avoid jailing of the contralateral limb. And in terms of precision, we mag it all up initially. We base it on IVUS, and we put the oblique stent in the correct direction. And we tend not to, when you deploy it, you keep it still and don't twist it. And I tend to just like poke it straight through the bifurcation. I just hang it slightly into the iliocable confluence. And I think you always feel that you're too high when you're actually not. So this is my favorite stent configuration. As you can see, I tend to use, this is a case of a bilateral that I did in a previous back surgery, where I deployed bilateral sinus oblique stents and extended down with the Venovo stent. I think one of the things with the Venovo stent that you should be aware of is that it is very stable. So where you put it, normally it stays. And you just got to open up the first stent and get some catch onto the wall. And actually, then you can actually fast wheel it down, and it opens up pretty neatly. So turning to anticoagulation, I'm a big fan of rivaroxaban. I know from the previous older data, you know, especially from the Americans, they were keen on just antiplatelet agents, but I think there's a real role for antithrombotic agents. And I think it's one thing that we should discuss actually about anticoagulation post-stenting. And I've had very little side effects using Xarelto, and I tend to do it once a day, a 15 milligram or 20 milligram once a day regime in the morning after their breakfast. There are patients with post-thrombotic syndrome or with thrombophilias, and I keep them on warfarin. That's my kind of policy for this. And then those who have got renal failure or on dialysis, I tend to keep them on dual antiplatelet therapy. And those with heart issues that the cardiologists want, instead of rivaroxaban, I'll keep them on a apixaban with a BD dosing. For this series, we had only 2 GI bleeds and 1 intracranial bleed. And since we started the deep venous program at SGH, over to a couple of 2.5 years ago, we've done about 170 of these cases with just very few, with all going on to either some sort of degree of anticoagulation and very few side effects from the Xarelto. I tend for the nivels, after 6 months, I will tend to actually switch them to an antiplatelet agent for life. For those who are on for PTS, I'll keep it at least for a year. For those with a thrombophilia, I'll keep them obviously for lifelong. I just really want to pull up this Delphi consensus, which was published only recently, about a couple of years ago, stating which anticoagulation should be putting on these patients. I think the thing that this consensus or this Delphi consensus came up to said a few things. I think those who are, that anticoagulation is preferred over antiplatelet agent, especially for the period of when the stent becomes endothelialized. I think also some people tend to like to use low molecular weight heparin for anticoagulation initially and then switch because they're worried about a complication. I've never seen that really very much. And I tend to put them on Xarelto the very next day with a baseline ultrasound scan of the stent. I think those following DVT, I think you can say safely to increase your anticoagulation duration for another 6 months, and then some of them will take off with anticoagulation after that if the ultrasound is normal. Also with those with multiple DVTs, I think the consensus suggested that all of them will probably be lifelong on anticoagulation. Whereas the issue with antiplatelets, I think people were still out there. I don't think there's that much evidence to do which way to go with that. And I tend not to start with that because I feel that you should have some anticoagulation on board. So in terms of stent patency and stent integrity for these patients, no stent fractures with the Venovo, as in keeping with the vernacular trial at 2 years. And you can see that the primary and secondary patency rates are very excellent with the stent. And obviously with nivels, you tend to get a better stent patency over that first 12 months, or we're actually up to than with PTS in general. At 2 years, actually, I haven't shown you the graphs here. These graphs are exactly the same. I've only had one re-intervention over that period of time. So in terms of looking at their clinical outcome, you can see there's an improvement in the revised VCSS scores pre and post stenting at 3 months. And you can see there's much improvement for the patient. In terms of pain, they're much improved as well. And what is the important thing is that in Asia, we tend not to really like, patients tend not to like compression because of the temperate climate and the problem with a 20-25% risk of dermatitis or eczema using it, especially in the heat. So these patients are very happy actually post stenting. And this is an ulcer healing rates have been 100% in these patients. And actually, I noticed that they heal much quicker and with better granulation tissue within the bed. And they tend to stay in remission longer than those who haven't had a deep vein stent. I can't really prove that yet, but that's just from experience. So in conclusion, guys, so the majority of our lesions here in Singapore are nivels. IVUS remains the gold standard for diagnosis and for treatment, in my opinion. Patients tolerate this procedure very well. They go home the next day, they stay one night, they go home the next day. There's good short-term primary and secondary patency rates, although we can say median patency rate now that we've got for this stent at 2 years is excellent. You get excellent clinical outcomes and you get good and very fast healing rates with ulcers. And this is actually a painting that was given to me recently by one of my patients who seems to understand the disease very well. He gave this to me on his discharge. He painted it overnight. And obviously, I think that's one of the things with this. You have to make sure the patient understands what you're getting into and what the deal is, especially with surveillance and with anticoagulation post-procedure. That's it. Thank you very much for listening.
That's fantastic, Tjun. Thank you so much. It actually fitted in really, really well. We had a hematologist who was going to talk about antiplatelets versus anticoagulation. And I think it's fairly easy to treat the patients who are acutely thrombosis and you've actually lysed and then you've stented. But the ones that have other chronic occlusions who you're treating and the NIVL patients, I think the jury's still out about the appropriate level of either antiplatelet agent or anticoagulation. So I'd like to take this opportunity to just ask the panel and poll the panel what they believe we should be using at this point in time. Should we be using aspirin, dual antiplatelets, or anticoagulation of some sort? Well, start with Ramesh. What do you think?
I use anticoagulation for all my patients, unless it is contraindicated, in which case I'll go for a dual antiplatelet.
All righty. What about you, Rick? I've lost Rick. How about you, Phil?
I'll unmute. I think Rick dropped out. Oh no, he's back. Rick was ready, so why don't you ask him and I'll come last.
Okay, you sure? Okay, Rick, what would you think? What should we be using in these patients with the chronic venous thromboses and the NIVL patients? I can't hear you. You're muted.
Sorry, yeah, I was starting to and then everything dropped out again. So so I'm doing anticoagulation 6 months, basic aliquot therapy, and now I'm more like feeling it. If I'm not too sure, then I also give a antiplatelet with it, just to be sure. I think I address that last time we spoke, because we don't have a dedicated venous surgeon here. I don't have that at my disposal. Therefore, I'm a little bit more worried. I have a little bit less options, and therefore I'm a little bit more secure, or I'm a little more scared actually that the stents will block, and therefore I give on a regular basis I add antiplatelets.
Fantastic. Phil, what would you think?
I think this is indicative that Delphi consensus is a good way of saying that no one knows. What I do is if I have a patient with a NIVL, is I put them on anticoagulation for 3 months. And if at that point everything looks fine, I continue them on close follow-up and I don't provide them with ongoing antiplatelet therapy. In my mind, they need anticoagulation while they endothelialize, and then they have an endothelium which is functional. The post-thrombotic patients are very different, as are the acute patients, and we treat the acute patients as per their DVT and whether they have a thrombophilia associated with that. And our post-thrombotic patients, we put them on 12 months of anticoagulation, and then like lifelong anticoagulation if we think it's high risk, or low dose, or antiplatelet agents, depending on the situation and their response and treatment. But there's great uncertainty, and even when you think about which anticoagulation you use, for example, Steve says he still uses warfarin for all his patients because he wants to know if their INR represents, I've been taking my tablets, doc, in his patient cohort. In my patient cohort, I use apixaban. I don't use rivaroxaban because they have to take it with food. And so I prefer them to have twice-a-day tablets and not actually, if they miss a meal or don't eat it with food, lose my effectiveness of the anticoagulation. So there's lots of different things, and different places like, in Singapore, are going to do it differently because there's different situations and different options available. But we don't have consensus around it.
But I still think there's growing evidence, even though it's anecdotal, that anticoagulation is the way to go. I mean, I started off doing antiplatelet agents, and the NIVL patients or post-thrombotic patients, there were a few that just came back with early stenosis or lining, mural thrombus that I thought, and it's described on the ultrasounds, lining the stent. And I started putting those patients and treating them with apixaban twice a day. And some of them regressed. And I thought this must be some sort of thrombotic process. So now I think it's extremely important in my mind that we get on top of it early and prevent that, because if they get that mural thrombus lining those stents, it's very difficult to get rid of it later on. And then we're sort of snooking ourselves for the next step if required. So that's
the difficulty. The difficulty, particularly with the NIVL patients who have pretty good results, is actually deciding risk-benefit ratio of, do I continue you on anticoagulation when you probably don't need it, versus the risk of anticoagulation. There's no way yet to determine, particularly when the patient's on anticoagulation and you're thinking about taking them off, are they a patient who's at risk of potential layering of their stent versus the other 9 patients who won't do that. And I think that's the difficulty, and that's the trick we have to try and get on top of.
True. But the good thing about our DOACs or NOACs is that their risk profile is pretty good.
Yeah.
Okay. The other thing, look, Tjun, I noticed on your talk, I thought it was really cool because you noticed a beautiful graph. And that reflects the 24-month, even though Venovo trial graph, where the NIVLs did something like 97% patency at 2 years. And it was an 83 or something % patency of the post-thrombotic group overall. I mean, you've obviously found the same thing, even though you're predominantly Venovo, but it just reinforces how good these stents that we're using now are. What do you think about that?
Totally agree. I think I was actually quite amazed, to be honest with you. I haven't actually re-intervened on any of these patients bar one, actually. And I actually follow them up quite closely because I give them a 6-month ultrasound scan. I use ultrasound. The guy in Taiwan uses CT venogram, but I don't like contrast and I don't like the radiation that they will get either way. So in terms of the 6-month ultrasound, if there's any evidence of new clot layering on the stent, they get an antiplatelet agent or they go back onto a NOAC, onto a Xarelto. So I think they perform, this stent performs pretty well. Also, I've not noticed any stent fractures below the groin. Now, I would say in about 15%, I've had to extend the stent beyond the inguinal ligament, with how few are. But those ones, they don't seem to fracture at all, either for this stent, I've noticed. So I'm pretty happy with how it's behaved. For those that I've taken really down below the groin, and I've had to, I've only done about 2 or 3 of these, and I'm not a big fan of taking this below the groin because I think the results are pretty poor. They've stayed open, you know, and but I've kept them on longer terms of anticoagulation. So I think it's basically on the individual, but overall the stent is performing pretty well. And I think with the vernacular data, and I've not yet seen the paper from that actually that's come out. They should have come out. Although they're waiting for 3 years, I wonder. But our 2-year data, and I think the Arnsberg registry from Michael Lichtenberg has just recently shown as well. His 2-year data using the Venovo stent is pretty much similar results too.
Fantastic. Right, we're going to move straight along and we're going to get on to Rick De Graaf. And Rick is going to be talking to us tonight. Rick was with us last week, and I know everybody knows Rick. That's right. Yep. And Rick is going to be talking about ancillary endovascular procedures and techniques to support iliofemoral stenting. So I'd like to hand over to Rick and take it away.
That's a very good idea. If they allow me to share, right. You should be able to see it. Correct. Right?
Perfect. Take it away.
The title, you know, what you do not know is that this talk, this is very experimental, everything. So it's definitely not something that that tomorrow morning when you wake up that you would really directly want to start with. So let's talk a little bit about the common femoral vein. We heard already about it a little bit, definitely on endophlebectomy a lot, and I'm going to add on that some. So we've been discussing that for a long time. What's going on there? The publications were not very positive on the common femoral vein or stenting below the ligament. Officially, it's called. So, and why were the results then poor? So could be the stent design. Neglen, of course, and Raju only used wall stents, maybe the specific design that they cause some problems, or probably some extensive disease. You know, because if the common femoral vein is involved, then usually also the femoral vein is involved and the profunder vein is involved. So, of course, they have less inflow, and of course that might very likely influence the stent patency. So then there was early recommendations not to stent across inguinal ligament. Probably that's totally bollocks. So that's we're done with that, I think. And it's also said in that paper from CSA that it might be more important to look for a healthy segment. The problem, however, exists when you have the common femoral vein involved, and there is not really a healthy segment. It's very likely not a completely healthy segment. There might be a less diseased segment, but not in this case. This is probably what we've seen most, severe post-thrombotic tissue disease within the common femoral vein. So it would be very difficult to find a specific spot to land a stent. However, with IVUS, you will be able to find sometimes let's say a spot where the trabeculations are not running across. So maybe the vein wall is thicker, but you might have some inflow from the profunder branches. So you find that the specific spot, but you need a lot of experience and feeling for that. Okay, is this branch more important than the other one? Can we stand across this one? Should we go for the other one, etc., etc.? So it's not something that you could put in a textbook. So endophlebectomy, of course, you can put in a textbook, and there's several hospitals that do that, or physicians that do that, all across the world. We in Maastricht. We did a series of patients, and we published that. And what's interesting, well, it's not interesting, maybe also, but definitely confirms my feelings around those procedures, were that they definitely not without complications. So infection, lymph leakage, we already heard about that, but redos are very, very high, 50% patency at 1 year, tops. So. And there's another issue. You need a lot of, let's say, redos without a stent occlusion. With a hybrid intervention, you do a surgical desobstruction, we know that, and place an AV fistula. Some clinics do without an AV fistula. I have no idea which one is better. Some say AV fistula, some say don't. But thereafter, of course, we need to evaluate what's going on. So what I used to do is then go from the contralateral side and get into that that PTFE loop that's placed, and then do an angiography through the balloon, and you can see if the stent is open at all. Thereafter, I inflate the balloon, I take out the wire and do an angio through the lumen of the balloon, thereby blocking the arterial flow, and you can see the spontaneous outflow, not inflow, but the outflow of the veins, and thereby you can estimate, okay, is this flow enough to leave the stent open without a fistula? Well, that's you have to be quite good to really make sure that estimation also is accurate. But you can do that. If there's really fast flow, you can close it. It would be more, well, let's say profound to leave the balloon inflated and then do an angio from the foot, because then you can also see the inflow and estimate if the profunda branches or femoral branches are good enough not to intervene. If this is all not really the case, if the flow is not good enough, you might do a stent extension. In any case, you need to close the fistula sooner or later, because that fistula that will cause intimal hyperplasia or another way of a stenosis or an occlusion. So you need to do another intervention, arterial intervention, go through that fistula and occlude it with an M-plaster plug that works best. So in the video, I put everything together. What happens after 6 weeks? Doing angio from the vein and say, okay, this is not really good, actually, right? Still collaterals and not a lot of venous spontaneous blood flow from the vein, but that's the profunda, and that looks pretty good. However, you need to notice that the common femoral vein is occluded again. So it's very difficult, but it is the only way to go forward. Go from the jugular, go through that occlusion. It's very highly fibrotic, and go through it. Then you have to inflate it truly with a high pressure balloon, because you probably need 25 to 30 atmospheres, and then stand across that common femoral vein that you actually did a lot of effort, or you made a lot of effort to open up that in the first place with an phlebectomy, but now still you need to stent it into the profunda, and you have a good inflow and outflow. So thereafter, this is the angio from the arteria. See that the flow is adequate. Put the balloon inside and see that the flow is still good enough. Now you see the phlebography from the foot with an occluded fistula, and you can see that spontaneous blood flow from the leg is good, and luckily this patient had a direct connection from the popliteal vein to the profunda, and thereafter over the iliac stents, a good outflow. So a lot of procedures, a lot of surgery, etc., but finally with a restenting and stenting across that endophlebectomy spot, you finally got a good result. So we published that it was good. To stent across the common femoral vein. That is a good option. So now experimental. What might be more beneficial for the patient? What can we do? So it's probably all inflow, I believe, because the endophlebectomy itself doesn't really do the trick. You need to stent, in many cases, you need to stent the common femoral vein after all. So you did something, not superfluous. So what you might do is place a endovascular fistula between the artery and the vein to increase the inflow. That comes from the hypertension research, where you place a fistula between the vein and the artery. There's the artery and the vein, thereby reducing the blood pressure. That's the idea behind it. But we might use it in veins as well, because when you look at these images, these MR venography images, you see that the artery and the vein obviously lie in close contact. So that counts for the common femoral vein and the common femoral artery, but definitely also for the profunda. branches and of the profunda femoral vein and the profunda femoral artery. So that might be a very interesting place to make that fistula. Theoretically, there are some example. This is a device. I don't know if it's on the market. I actually do not know where I got the video, but I found it on my computer last night. That is a device where you go with a sheath. You puncture the artery in the vein. You go with a wire through it. That's not a big deal. Of course, you can do that with a sharp needle. And then put a sheath through there, and then with such a device going through that orifice that you created, and you place a some kind of disc. I'll go through that because it's right. You go with the sheath and device through that orifice, and you get a disc on the one side, pull it back, and this from the other side, and thereby creating, when you pull it out, creating a AV fistula. So probably a lot of techniques possible. What I have some experience with myself is this system. Now, I used to be from TVA. Now it's actually BD that bought it. I don't know if it's available everywhere actually. It's an Everlink system that's created, that's used to create a arteriovenous fistula for a hemodialysis shunt, and it's a radio frequency electrode that cuts a hole between the artery wall and the vein wall. You can see it here. This is of course in the lower arm. You should use this device. Did quite a couple of those, and that works well. But that's a different different talk. You align those two catheters. They have they're magnetic, so they come very close together. There you see that little radio frequency probe, and that's very accurately aligned. So, and thereafter, energy is released. So first it's attached, and then by a little push of the button, you see that little probe going toward the other side, and thereby directly cut a hole, and the fistula is established. I think you see that on the angio in seconds, right? So this is an arm, but it works exactly the same in a profunda vein. And I'm very disappointed, a little bit annoyed because I did a cadaver study with that device to actually see that it works, and it did work at the profunda vein very nicely. But somehow I misplaced those videos, but it really worked nicely on that in that specific case on a deceased human being. So, and then there's another possibility. This is a book that we wrote together, and Mark Garcia wrote an article on that, on femoral vein recanalization, because that might be another way to, if the inflow is not good enough, to not do an anaphylactomy, but to treat the femoral vein so more inflow comes from the lower leg, which actually makes sense, because then the patient also has a spontaneous outflow, thereby reducing their complaints. So, and these are pictures from that article. So this is a completely occluded femoral vein, and what Mark Garcia is doing and what he published is that that's doing a PTA, and thereafter place the patient under echoes lysis and thrombolysis. The exact mechanism I'm not completely familiar with, or maybe even a little bit skeptical, but he published it, and the results are really, really good, and you get a nice inflow from the popliteal vein and the femoral vein, thereby also increasing the patency of the iliac vein stents. So that might be another option next to the AV fistula. So for discussion, I think if spontaneous venous stent inflow is insufficient, right, are additional procedures at all valuable for the patient? What I mean with that is that if you have a very, very poor inflow from the femoral vein and the profunda vein, you can, of course, place a fistula or do an endophilebectomy and place a fistula, and the stent will stay open. But there's not enough outflow from the leg. So if there's not enough outflow from the leg to have the stent stay open, then why would the patient be better after? Because there will still be venous hypertension in the calf and below, right? So if an additional procedure is deemed valuable, then is a surgical desobstruction with or without an AV fistula the best solution? And should we negotiate at this moment endovascular techniques to improve inflow in the stent? Thank you.
Thanks, Rick. That provokes, very thought-provoking, and quite a lot there. I mean, I don't know. I'll just start with one of your comments you were saying about endophilebectomy with 50% patency rate at 12 months. Ramesh, what do you have to say about that one?
I don't agree with that. And I think our experience has been pretty good. We've had wound complications, but we have not really had patency issues with these patients, and mainly because we do extensive clearance right into the femoral vein, and also, if necessary, we open the profunda vein and clear the bulk in the profunda vein, and we do on-table venograms to make sure that the profunda inflow is excellent. Regarding restenosis, I have not seen, I think among the patients, we had one patient who came back, actually had a stent put into the profunda orifice. And it's probably because there was a lot of disease in the profunda orifice, and which we were not able to clear surgically. But apart from that, wherever we have been able to clear completely, we have had good results. I don't use AV fistulas because in our experience, we did put AV fistula in one of our cases, and actually it made the chronic venous insufficiency worse by increasing the venous hypertension lower down, because I think in that patient, there was already valvular damage, and so the pressures were also carried distally. And so I don't use AV fistulas, but I do a generous clearance, and our endophilebectomy rates have been okay. And since we started doing this delayed closure and vac dressing for, to take care of the wound complications, the wound complications are not a problem in a major way. And actually, I've not had a single patient who had infection following endophilebectomy. So I'm surprised at the infection rates in Rick's quoted series.
I've got to say, I think you are probably very experienced in this. And like a lot of the people who are watching and a lot of the vascular surgeons and interventionalists out there do not have a lot of experience with endophilebectomy and will be using stenting more. And I can see where Rick is saying we actually need good inflow and good outflow. And Rick, you're stenting into the profunda or into the femoral. How do you base your decision? Which one should you be choosing? Is it based on IVUS or the flow that you see on venogram, or?
Yeah, I hope we have time, because now it's really starting to get interesting. So the Maastricht group, I think I would roughly have to estimate, because we started in 2009. We did 1 to 2 a week, now already for 10 years. So do the calculation. That's quite a lot, and a very experienced venous surgeons, and they did a lot of different tricks with the fistula and the straight or in the loop or whatever. We only treated the very, very most difficult patients. So that means the heavily obstructed femoral vein and a heavily obstructed profunda vein. And of course, when we compare patients, when we compare groups, we need to know what we're talking about. And of course, you have those patients with a, just in the most distal part of the profunda vein that there's an obstruction there, and the rest of the profunda is actually very, very good. You might get away with that to clean out the orifice. But I asked my vascular surgeons many, many times, and I never got a straight answer, to be honest, almost like politics, is that okay, so we've been saying now for years and years that we should not do only PTA, right? PTA doesn't work and we always need to stent. Okay, fine. So we do that. But when you have an endophlebiectomy, then you can only go for so many centimeters inside. So what do? They use some kind of clamp or something, and then open up a little bit, right? And you see a spontaneous blood flow coming into your face, and it looks, oh, this is very, very good. And then you do a phlebography a couple of minutes later because you closed it, and it looks very, very good. But that's not how it looks after 2 weeks, because why would that little surgical technique work, but a complete PTA would not work? I don't believe that. Plus, I've seen all the disasters or the let's say the closures, because I did all of the evaluations from the arterial side and see if they were open. And most of the common femoral veins, the endophlebiectomy sites, were actually highly obstructive or completely occluded within six weeks. So that is a huge thing. I must say, of course, again, I'm not a surgeon, and Ramesh is experienced, and his idea with the VAC and not closing is probably a very good idea, and also precludes then the reocclusion at the endophlebiectomy site. That's all possible. So, but now your question. So I now, without a venous surgeon on hand, I like to look for the best spot in the common femoral vein. If that's not there, then usually go for the profunda. Why? Because the profunda is usually, in most cases, it's large and it's fairly free of disease when the popliteal and the femoral vein are occluded. Why is that? Because usually the DVT goes down. If you believe in the descending and ascending DVT theory, then goes down to the femoral vein and popliteal, and then you go from popliteal and clean everything out. But the profunda is most likely not completely involved, only the first 2-3 centimeters, and there you see the post-thrombotic disease. And when you manage then to go from the contralateral side of the jugular vein and go into to the profunda, you have a nice 12 millimeter profunda going into the and stenting just a couple of centimeters further. That I don't see that specific stent extension reduces stent patency illically. So sorry for that long answer. I hope I addressed everything.
Steve, can I say something?
Sure.
Rick said that he stents those patients where the profunda is involved in the first few centimeters. And these are the patients who are easily accessible to endophlebiectomy, because once it goes into the branches, these patients are not suitable for endophlebiectomy. And they're not suitable for stenting either. So if there is an involvement of the main branch of the profunda, then they are suitable for endophlebiectomy and or stent that way. But which way you want to go, I think it's a preference depending upon which center you are and whether you've got experienced venous surgeon. And I'm pretty comfortable that if Rick doesn't have an experienced venous surgeon in his center and he wants to stent across, then it's a perfectly reasonable option. But the point is, what happens if that stent blocks out? What are the options after? Because if the endovenectomy undergoes restenosis, you still have a stent as an option.
I see where you're coming from, Ramesh. I do. I'm going to move on. Just the question about the fistulas. Now, Ramesh, you don't use a fistula in your endophlegmectomy, but I can see that there is a benefit for improving the flow through your recanalized or reconstructed veins, whether they're stented or not. With one of the images that you showed, Rick, it was a beautiful little stent that pierced both sides of the wall. Usually when we have fistulas, we construct them with veins or with PTFE. Sometimes they enlarge with time. Do you think something like that, where we can construct a tiny little hole that will improve the flow through the vein segment, will improve our patency through dubious segments of veins that might not have good inflow? Well, I mean, what's the thoughts out there on that?
So you address two things. So the patency of the fistulas
so when we're treating, we know we need good inflow and good outflow. And if we've got some problems with our inflow and we're treating a profunda femoris vein, do your novel device that actually created a small fistula, which was what, a couple of millimeters in diameter? Do you think that there may be a role for this in the future?
Yeah, I really do think that it's that might be a role, might have a role. The only, so I think you asked, does the hole get bigger? There's data on that.
Well,
and
depends on what you use. Like if you use a vein, it will grow in size after time. And if you, that's the question about timing of closures of fistulas in your venous reconstructions.
I really, so this specific hole from the Everlink that's been proven that stays the same, and you don't get any intermyoplasia or closure after a couple of weeks or months. So that's really durable. The problem might be that you have a tank. How do you say that in English? So the flow is not with the venous flow, right? So you might endure some retrograde flow, which you do not like. So that might be an issue, and the closure of the fistula might be an issue, because the only way to close such a fistula is surgical or with a covered stent from the arterial side. So, and that's not something that you're always talking about those patients, venous patients. That's not nice to have, but it's not disastrous. So you don't want to mess too much with the arteries and then create a problem there. So therefore, I really want to point out this is highly experimental. It might be interesting for the future. But it's not something that we should already start using in patients, although it might be possible, because we may see more problems in the future than we can handle. But it might be not interesting option.
Steve and Rick, I think I don't understand the concept of AV fistula, because with the AV fistula, you're treating a procedure that is keeping the stent open, but you're not actually, treating the chronic venous insufficiency lower down. And the patient may still have an AV fistula and still remain with a venous ulcer or advanced disease that you will not treat because the inflow is still not good.
That was actually my point in one of my discussion points. So it was thought always to have the AV fistula there to at least keep the stent open for the first 6 weeks, and then close it, and then you have the nice inner lining, and you have less risk of low risk of rethrombosis, and the venous flow can take over by itself. All the issues we've seen, the restenosis and retrograde flow into the femoral vein, increasing the problems in the patients, high venous hypertension, ulcerations, etc., etc. So definitely, I'm not per se in favor of that fistula. The only thing is we need to do a patient selection. That was one of the questions that I asked. Are there maybe, I think there are, is there a cohort of patients that we should not treat at all because the blood from the leg will never ever get to the stent wherever you're going to land it? So we have a stent, maybe closed, maybe open with a fistula, but the patient is definitely not going to get better because the flow is probably going to find some superficial branches and everything, but it's definitely not going to reach the stent. and there's absolutely too little discussion on that.
On some occasions, there is a operation called May-Husni operation, whereby you can use a saphenous vein to bypass the popliteal to the common femoral vein, and that can improve the inflow as well.
Yes, but what I mean is those patients that are really completely post-thrombotic, obstructed, so also the femoral vein. When I see extensive disease, so beyond the common femoral vein, it's very unlikely that the popliteal vein is certainly beautifully open. It's also tuberculosis, also the calf veins are post-thrombotic. I think those patients are will be very difficult to help with any procedure. And those patients, that's what I'm talking about. Of course, you have the very nice post-thrombotic obstructions that end at the ligament or a little bit below. And then you have those that you can stent into the profunda, do a nice inflobectomy with a good inflow from a femoral vein or the profunda. But I'm talking about that. I think it's about 10%, 5 to 10% that are completely obstructed. And what should we do with them? Is there a possibility? Maybe Marcasia has a very nice opening there. I don't know. I tried it once. It did stay open, but that's one. So that might be interesting, PTA and lysis. But I'm really looking for those specific that specific patient group.
Yeah, I think that's the next step we're all looking for. We need to look at that femoral vein, but we need good inflow and good outflow. And I can see that you've gone down with your stenting all the way into the profunda to obtain good inflow. And once you get that can maintain patency. So, yeah.
Sorry. No, sorry? It's a little add-on on that vein fistula, because then you have a stent length of probably almost more than 30 centimeters. So I don't know, but it might be step by step. So if you first have the iliac stents and they're accepted, and they have an inner lining, and thereafter you do a stent extension, that might work. But maybe 30 centimeters of stent with a spontaneous inflow only from the profunda might not work. Absolutely no proof, just an idea.
But it's all up in the air. I mean, we don't know really how the stents will react in that area. What size do you use in that particular segment?
So we did have the possibility to have, they Optimed made a 10 millimeter stent. I don't know if they still do it. I thought they only made it from Maastricht, but we did it with a 10 millimeter stent. But then I had a long discussion, and it doesn't really make sense, because you do a iliac stenting with 14 or 16, and you go down to a single inflow stenting, a single outflow stenting with 10 millimeters. So there's no inflow along the way. So you go from 10 millimeters to 16 without additional inflow. That doesn't make sense. Then you have stagnant flow and thereby thrombosis. So it would be better to have one pipe, maybe go from 14 to 12. Therefore, if I cannot place a 12 stent, then it has no use. So I would never place a 12 millimeter stent into a 6 millimeter or 8 millimeter profunda veins. That's nonsense.
Yeah. Any other comments for the panel?
Yeah.
Sorry, Ramesh, go for it.
If you overstent the vein, then again you destroy the compliance and cause more thrombotic changes in the vein, or even increase neointimal hyperplasia, so as to speak.
Yeah. Any last comments, Tjun and Phil?
Just one thing about this thing. Can I just ask you about what do you guys think about this thing? How do you know what is good flow into the leg? I always ask that question to myself post within a PTS patient. What do you say is good enough flow? I just still don't get that handle on some of these PTS patients got occluded veins below their groin. I mean, and when, AV fistula, I'm not totally convinced either about AV fistula. I have colleagues putting them in. They say, when should you tie them off, or should you tie them off? And I'm thinking with that kind of the Everlink system, you got a hole between the artery and vein. How do you close that hole off as well if you wanted to in the future? It's going to be pretty tricky.
That's tricky. I look at the the evacuation of the contrast to assess the flow? I mean, how do you guys do that?
Yeah, I do that, but that's absolutely not. So I did a couple of things. Once I think for Link, I did like I showed 8 cases or something, and then said, okay, what about this inflow? It's a beautiful inflow. So open or closed. Next day closed, beautiful inflow, and very bad inflow or flow through the stents, and some stagnant flow and everything bad. And so okay, still open after I think more than a year. I did one case long time ago when Steve started in London. And and I said, okay, Steve, you cannot leave it like this. This is the worst I've ever seen. This cannot stay open. You have to do some other surgical tricks. They said, no, I'll take the risk, or whatever we discussed, or we want to have a beer. I don't know. So anyway, he's still saying this. This is a long time ago, and the patient's still open, and that was really bad. So in short, we have no clue. Of course, a beautiful outflow within 2 seconds. That makes my night a lot easier to sleep. But there's absolutely. I'm still a little bit. My heart still skips a beat when in the morning I do that first ultrasound before I discharge them. So I don't know.
Always scary,
Yeah.
and that's why.
Yeah, I was going to say I agree. It's actually very hard to determine what's going to work and who's going to get the benefit. Some ways the way we look at it is whether there's hold up in contrast, but that's not objective, that's subjective, as Rick said. The other thing with intravascular ultrasound, of course, is that we can look for that grayness of blood comparative to when you've stented it, and hopefully with good flow there's blackness because it's moving, it's not stagnant. So this black blood in IVUS is reassuring, and we think, yay, terrific. But once again, it's completely subjective, and you can't objectify that and put numbers on it at this stage. And I'm sure that we'll try to understand in the future, but we've got a long way to go. And I think this whole evening is a great discussion about how much further we've got to understand the impact of everything else in the leg to what we're doing to the iliac vein in this instance. Is still a lot of unknowns and a lot of things to learn and grow from.
Excellent. Well, look, I'm going to stop us there. So, because we've had a lovely discussion tonight, we're going to finish up, but we are having our final session in 2 weeks, Wednesday, the 28th of October. We're going to get together Jerry O'Sullivan, Stephen Black, and Rick De Graaf, and it should be a very eventful evening. They're going to give us a few talks on topics that they'd like to discuss and that we can get the most out of. So I'd like you all to clock in on that night and share with us your time. And also, as other thing, is to send in your questions. If you have any pressing questions that you would like answered, I'd like you to get that in the Friday before the 28th of October. Alex will be sending out Alex Hassan from BD will be sending out some emails with this information. But if you do have any pressing questions, I'm sure any of these three could answer them very well. So I'd like to thank our panelists tonight. We have Ramesh Tripathi, Rick De Graaf, Tjun Tang, and Phil Puckridge. We've had some excellent discussion, and thank you very much for your time and spending tonight with us. So I'll close off the Venus Forum there. This is that QR code if you would like it. So thank you very much, guys.
Thank you.
Thank you.
Thank you.
Moderating, beautiful.
Thank you.
Thank you.
And we are
almost. Are we stopping recording, Khaled?